are going to talk about today we're going to talk about integrated care, but we're specifically going to look at sexual and reproductive health in terms of that being one facet of integrated care. So because integrated care can mean so many things, and when we talk about integrating primary and mental health care, primary care means lots of things. And for many people in the world, sexual health and reproductive health is a very important piece of, of all of this picture. And because we're talking about sexual and reproductive health, it's kind of like 1.5 facets of integrated care, I guess. So we don't really talk as Americans, and I'll generalize, and please argue with me or disagree. I'm happy with that because for myself, I would say that it's pretty fair to say that we don't really talk about sexual health or sexuality in, polite company. But sex and sexual health is a major part of nearly every human life at some point, and good sexual health is a basic human right. The World Health Organization defines sexual health as a state of physical, emotional, and mental and social well-being in relation to sexuality, noting that it is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. Research does indicate that participants with severe mental illness or serious mental illness tend to have lower rates of being in a long-term relationship, and that includes but isn't limited to marriage, and have lower rates of sexual activity in the last 3 months when surveyed compared to the general population. That said, like all human beings, normal sexual development for FEP participants includes periods of ambiguity or exploration and changing needs over time. These are things that we should be aware of. And I don't want to start bleak, so I'm not going to stay here long, but April is Sexual Assault Awareness Month. And sadly, participants that you work with are at an elevated risk of sexual assault and intimate partner violence. In fact, this is one of the potential causes for some of the sexual and reproductive health disparities that we're going to discuss. In the event that you work with a participant who's had some military experience, particularly females with some military experience, this might be an area to really dig into a little bit further, as the Veteran Administration has acknowledged that there is a far disproportionate amount of sexual assault against female military personnel. So on to the disparities. Individuals with serious mental illness tend to have statistically higher rates of sexually transmitted infections, higher risk sexual behaviors, things that would include unplanned sex, unprotected sex, multiple partners, potentially sex as trade for something, higher rates of unplanned pregnancy, higher rates of recurrent miscarriages, and higher rates of abortion. Individuals with serious mental illness are also less likely to access routine sexual and reproductive health services, including prophylactic contraception. They're actually are more likely to access emergency contraception. But the big result of this, in addition to the things noted on the last slide, include an array of gynecological diseases, which you can see the list here, some of which can impact fertility. So higher rates of cervical cancer, polycystic ovarian syndrome, thyroid abnormalities, endometriosis, and the list goes on. So why do these disparities exist? Well, as we've already stated, disproportionate rates of sexual assault and domestic violence and victimization across a variety of arenas could impact some of these disparities. Probably the most talked about reason, particularly in our space, is side effects of medications. This is at least one thing that our prescribing and nurse providers might more commonly ask about, which is good. But medications can cause more than just sexual side effects. They can also impact reproductive health, causing infertility, having an impact on the fetus. And which literature actually does indicate that persons with serious mental illness statistically have higher rates of infertility than the general public. So don't ask me to elaborate on the medication concerns. We'll have people on the call that could much better answer those kinds of things. I am a counselor. I will very happily stay in my lane as to how that happens, and but nonetheless, other potential causes of the disparities could be things like comorbid health and lifestyle factors, things like smoking, substance use, obesity, and all of your standard social determinants of health, because all of those things also impact sexual and reproductive health. Additionally, health literacy can impact sexual and reproductive health. So just how familiar people are with the things that they need, should be familiar with, asking the right questions to their medical providers. And there might even be a less perception or awareness of the overall risk that they might be at. Interestingly, when it comes to engager in higher risk sexual behaviors, that's also a correlation with poorly rated quality of life or more fatalistic views of the future. So, when interacting with somebody who maybe is reporting a poor quality of life, or it's expressing fatalistic views, that is a person that might be at a disproportionate higher risk of engaging in some potentially risky behavior that puts them at risk for more disparities. So given all of this, what would you say? Are we discussing sexual and reproductive health with your participants? I can't see everybody, so I'll rely on Nick and Crystal to look at any show of hands that's going on right now, but I'm guessing we're not talking about it too much, and the literature tends to support that. So why not? Sex is kind of a taboo topic. It just is. There's a fair amount of discomfort talking about sexual health and reproductive health in polite company, and some aspects of sexual health and reproductive health have become highly politicized. Certainly not here to discuss that, but it does warrant some acknowledgement that this becomes a very political space for many individuals, and that should be a conversation that we're able to have. So we might not bring it up as providers, and participants might not bring it up. When surveyed, providers often note feeling uncomfortable or that it's outside of their scope of practice. So maybe even feeling like, well, I wouldn't know what to say or how to advise somebody. Providers also say that they hear a lot of complaints about loneliness. So then they kind of make this assumption that they don't need to talk about sexuality or relationships, because if they're lonely, then they're probably not having sex. We shouldn't make that assumption. Providers also worry about bringing it up, possibly identifying a need and then not having a good resource to point the participants to. So, you don't want to identify an issue and then not be able to handle it. And similarly to all primary medical care, access is an issue. So access to sexual health services, blood work, pregnancy tests, good contraception. It is, it's a healthcare access issue, which is not a huge surprise. So providers report that overall sexual health and sex and reproductive health is kind of deprioritized as a topic, because when you look at it in comparison to other symptoms or concerns identified by the participant, it just doesn't feel as important. There's more pressing needs going on with what's going on with them right now that you have to put your energy into. So sexual health gets put on the back burner. Providers also note feeling that there's conflicting requirements, like confidentiality versus safeguarding. It's hard to know what to do if we suspect an adult participant is being exploited by a romantic or domestic partner, especially if that participant identifies that partner as a support system, but then we're questioning if there's kind of a sexual exploitation piece to it, and when are we supposed to jump in? And unless the participant has a guardian, we don't necessarily have cause to breach confidentiality in some situations around domestic violence when it's between adults. And then risk management versus health promotion. And interesting, providers note in one of the studies that's referenced that they were more likely to address sexual and reproductive health issues when it was a risk management issue, because then they have to make sure that their liability is covered. So, for example, if there's a failure to share health information with a participant that becomes pregnant, there might be medication that continues to be prescribed that shouldn't really be taken during pregnancy and could impact the fetus. So this becomes a risk management thing. So that's the time that sometimes providers are more willing to jump in, because now it's risk management instead of just health promotion. And of course, providers bring their own stuff to these conversations. This was a quote from one of the studies that I looked, they did some focus groups. And so the quote says, there's something in our training, in our experience, social expectations. People bring dilemmas about relationships and their sex lives to the team. I think sometimes the most difficult conversations, because in the face of it might be a bad relationship, but who's it, is it really for us to say? So we make these, we make assumptions, we bring our own stuff, and as personal as sexuality is, that makes sense. It can be hard to separate our own beliefs and norms when discussing it with others and trying to remain objective about participants' relationships. It's important to recognize and remember that there's a wide array of what's healthy, normal, acceptable, and romantic and sexual relationships. What works for me won't necessarily work for you. So we need to make sure that we're not making judgments or assumptions. On that note, providers do sometimes have pretty biased views and attitudes that impact how we talk about sex, relationships, and sexual and reproductive health with participants. One example that's noted in the literature is this false idea that participants are somehow asexual. Goodness knows how that myth got originated, but it pops up. So providers also might have some strong ideas about the participant's skills or abilities related to parenting. And one of the studies showed that negative judgments about the ability to parent was stronger when it came to mothers with severe mental illness. So, having a much more judgmental attitude about her capacity to be a good mom. Providers also note feeling fearful that a participant gets into a relationship, they might have to take on, caring for that partner, or if they have kids, what if I now have the extent of my responsibility in this case now extends to the family and the children, and how much more do I have to worry about? So there's, a little bit of a concern about taking on additional responsibility. So when participants are asked in surveys and focus groups, they report a handful of common challenges and concerns regarding relationships that are important for us to keep in mind. Common concerns are around challenges just meeting new people and meeting people to potentially be in a relationship with, expressing and reading emotions, which can make it hard to navigate a romantic relationship and can be hard to navigate as a parent. They commonly report concerns about financial security. Can I afford to take this person on a date? Are they going to judge me if I can't, afford to go somewhere better? And also not wanting to become financially reliant on another person. Finances and sex are two major topics in, romantic relationships that can cause a lot of division. So obviously there's going to be some real concern there. The most common, largest issue of concern, though, was actually external and internal stigma. So self-esteem, feeling like, maybe I can't be as picky about choosing a partner because I won't have as many options. Fears about starting and maintaining a relationship and about decisions around starting a family. Decisions about when to disclose illness. And then what if the participant and partner both have mental illness? And what if we're both not well at the same time, experiencing symptoms at the same time? Does this put extra burden on each other? Does it put extra burden on children? So again, the impact on partners and kids. And then fears of social service involvement. And sure, we can all think of scenarios where we've had somebody in social service got involved, maybe at times that it wasn't really warranted, but they kind of got involved because of some biases being in place and people making assumptions that shouldn't be made. So I just grabbed this screenshot. It's probably not super easy to read. I acknowledge that, and I will make sure that you get a copy of the article that this comes with, so I can have a PDF, and there's also a link to it. But they actually did a thematic map on the Dubrecht study of the themes and sub-themes reported during focus groups. And the focus groups were with persons with severe mental illness and providers. And it was all about the decision-making around intimate relationships and becoming a parent. So a wide array of things that could be considered, but all things really for us to take a look at when we're working with participants. And so despite all the challenges, disparities, what have you, being in an intimate relationship and becoming a parent is reported to be a strong motivator for recovery. With study participants noting that such socially valued roles can provide a buffer against some of the detrimental effects of self-stigma. And as providers, we can do some things to help support participants' sexual and reproductive health. So foster hope, normalize worries, engage in the conversation. Try to provide accessible information and education about sexual health, pregnancy, contraception, kinds of things, reproductive health, to really help participants feel empowered to make decisions. Support the development of coping skills, social skills, offer parenting classes if that's something that's an option, and peer-delivered interventions were strongly sought after. And as always, when appropriate, engage things. Family involvement and support is important for many participants, and their support can be really beneficial in promoting sexual risk reduction activities. More things noted that we could do to help support folks is, enable the conversation. Make sure that this is a part of standard care. So asking as part of routine health screenings, asking about sexual side effects, asking about, what sexual practices are. Use a screening tool if it makes it uncomfortable, because if it's on a form now, it kind of gives you permission to ask. Sometimes that makes it easier, makes it less uncomfortable. So, well, it just, it's on here, so I have to ask about it. And, doing that with everybody. So nobody feels like, well, you don't ask everybody about this. Just make sure that you do. Facilitate and accompany service users and participants to primary care offices and appointments, or to, OB-GYN. And improved training for staff is something that's noted in all of the literature. Give us more training and then we might feel more comfortable talking about things. And an important note, we all need to be mindful to not fall into the trap of heteronormative assumptions. You set yourself up for failure pressing on condom use with a female who exclusively has sex with females. You're unsure about the biological sex, gender identity, any of that with your participant or their sexual partners. Don't assume, just ask. And I wanted to give you a couple just quick resource ideas from two of the reference studies. They actually looked at implementing sexual and reproductive health interventions pretty successfully. So with this one, a team of researchers, mental health and sexual health workers, and persons with lived experience developed an intervention to help people with severe mental illness to increase their knowledge and understanding of sexual health, including contraception, use of condoms, STIs, and considering safety and assertiveness in intimate relationships. It was delivered over 3 sessions, 1 hour each, by a trained mental health provider. And they found that overall people thought that this was a comfortable thing to participate in. It was safe, acceptable. It was pretty easy to attend. And they actually got a better recruitment when they started going directly to participants rather than trying to get referrals through therapists. Like, look at your caseload, tell me who you think would be good. And skip that, just go directly to the participants and see if they're interested. The second intervention was actually a follow-up to the focus groups from the Dubrecht study. And they had 2 facilitators. They created a manualized, structured, strengths-based group psychoeducation. So 16 sessions, and it was 2 8-session modules on, one on intimate relationships, the other on decision-making around family. And there is a link there because the table that was included in the article is pretty lengthy. It gives you all the topics per session. So the things that if you have somebody that you're working with that you really wanted to dig into some of this, they've got a pretty good structure built around. And just another little resource for educating ourselves and something to refer back to. So Sexuality Information and Education Council of the United States, or Sex Ed for Social Change, as the website notes, which I thank them for doing that because that was a mouthful for me. So their goal as an organization is to advance comprehensive sexuality education as a means of building a foundation for long-term culture shift that'll positively impact all levels of society, particularly issues around gender and racial equity, sexuality, sexual and reproductive health, consent, personal safety, and autonomy. So they actually put together the National Sex Education Standards, and you can find those standards on their website. And it goes into topics like, what does quality sex education include? The importance of keeping a trauma-informed lens, looking at social, racial, and reproductive health, justice, and equity, and intersectionality. And it leans on social learning and social cognitive theories around self-efficacy. So if that's an interest, it's a good resource. If you're working with somebody on this, you might want to have good education in front of you so that you know that you're providing the best information to them. Here's my list of references. I am happy to try to answer questions. And I'll stop my share.